Everybody, this is Dr. Matt Love. Thanks for tuning in tonight. It looks like we got a pretty good crowd so far. Just a quick introduction to the topic for tonight. So we're going to talk on another important men's health subject, understanding and treating urinary problems, what we call BPH or enlargement of the prostate. So we're going to kind of start off talking a little bit kind of about the whole idea behind enlarged prostates, symptoms that arise as a result, and kind of work our way up from the conservative sort of first line management all the way up to multiple different surgical options and kind of run the gamut tonight. So a quick introduction. Again, Dr. Matthew Love. I'm kind of on the north side of the city, Butler County area, Fairfield, Hamilton, Ross, and I also operate down our surgery center in Norwood. I am a general urologist, but do a fair amount of enlarged prostate, overactive bladder, kidney stones, kidney cancers, robotic surgery, etc. Fortunately or unfortunately, a Notre Dame graduate, so I know that's hit or miss around this neck of the woods. But went to medical school down in Louisville and residency in a prelim surgical year at Vanderbilt and Georgetown University. So we'll dive right in. Managing your overall health. There's been a little bit more of a push towards men's health over the last couple of years. What are the things that we can do to not only increase our lifespan, but also quality of life? A lot of these things are common sense that sometimes we don't always do the greatest job. Diet, exercise, good sleep, mental health, avoiding all the things that we know we should avoid. And this does kind of play in a little bit more into prostate health as well, and particularly irritative or annoying bladder symptoms. So first poll question, we'll try and get people a little bit more involved tonight. So the first question is, what does BPH stand for? So I know not everyone out there went to medical school or is in the medical field. So far, it looks like we're getting some perfect scores. So it looks like this will be an easy couple questions for you guys tonight. So we'll go through a couple more of these poll questions as the night goes on. So you guys generally are very accurate. BPH does stand for benign prostatic hyperplasia or hypertrophy. It's often referred to people talking about, I have a swollen prostate, I have an enlarged prostate. This is all kind of the same disease process. So with BPH, benign essentially means this is a non-cancerous, non-malignant type of condition. This is something that is very treatable, and this is also something that is very, very common. There's close to 50 million men in the U.S. alone with this condition. And typically when I have patients coming into the office, depending on their age, try and give them a little bit more reassurance up front. If we've ruled out the other bad stuff, how common or uncommon is this condition? I think there's a lot of men out there that just don't love talking to family and friends and their spouse and their dad or their brothers about, the urinary issues that they're having. So this is something that is very common. About 50% of guys in their 50s, about 80 to 90% of guys that are 80 or older. So again, something that's very, very common. This doesn't mean that every guy with BPH needs a surgery or needs multiple medications, but it is a very common condition, which we see very regularly. And also a lot of patients that probably should be coming to see us that are not, and just kind of dealing with it. So as men age, prostates get bigger. And this is a little graphic here to kind of show that. So you can see kind of the bladder on the top side of the screen, bladder partially full of urine. The prostate is kind of the first part of the urethra, which is the tube that you pee through. So a normal, healthy bladder, normal, healthy prostate, when that bladder squeezes, there's not a whole lot of obstruction, and that bladder is able to empty with a relatively low force. Now, again, as men get older and as prostates get bigger, that process that the bladder has to accomplish to empty the bladder efficiently, effectively, without causing you quality of life related symptoms, that bladder has to start working harder and harder. So some guys will come in and say, it's just a little bit of a weaker stream, a little bit more trouble getting started, or trouble emptying my bladder completely, or really that feeling of not being empty. The challenge is some other guys will have what we call irritative symptoms rather than obstructive symptoms, meaning, constant frequency, urgency, feeling like they need to go, waking up a lot at night. And this sometimes can just happen as that prostate grows and kind of pushes within the bladder, causing a little bit more irritation. Other times this can happen as that bladder is just being overworked for, not just a couple of weeks. This is something that, again, is typically progressive, starting 40s, 50s and beyond, where that bladder muscle begins to thicken a little bit. And so in our practice, our job is to obviously help, rule out problems, help with quality of life. But part of our job is actually educating patients on what some of these symptoms that you're experiencing can mean. Because again, kind of going back to what I initially said, a lot of patients just say, well, my dad dealt with it. My brothers and my friends are all kind of dealing with the same thing. This is just normal. Well, it is to a degree, but there are things that we can do to really protect that bladder health. And one thing that I tell my patients who come to see me for these BPH related issues, we can fix an enlarged prostate, whether it's medications, whether it's minimally invasive surgeries, whether it's more maximally invasive surgeries. What we can't really fix is a bladder that's worn down. And so a bladder that's been having to work overtime for years and years and years begins to be much more of a problem. And we'll kind of talk about some of the side effects that patients can experience if these symptoms go ignored for far too long. So to kind of run through, what are the symptoms that people with BPH have? And it's a pretty long list and probably even longer than this. So again, it can be difficulty initiating flow. It can be a weak stream. It can be an interrupted stream. It can be some discomfort with urination, frequency, urgency, waking up at night, feeling like your bladder's not emptying, or even sometimes, leakage of urine, which again, sometimes is kind of heading into the more progressive area of BPH. So a pretty wide variety of symptoms that, again, a lot of guys that are in this age group are probably at this talk tonight are saying, well, I could check the box on at least a couple of those. So going back to that idea of bladder health, I think this is a really important concept. And I think us as urologists haven't done a great job of educating people. The patients that usually end up in our office are the ones that have much more severe issues and sometimes problems that we're not going to be able to fix as well as we would have maybe 2 years earlier, 5 years earlier, 10 years earlier. So over time, as that bladder becomes weaker from just being overworked, or that prostate gets bigger and prevents you from emptying all the way, patients will have stagnant urine that just sits in their bladder. That can cause bladder stones. That can cause urinary tract infections, which can potentially be quite serious or even life-threatening. The other thing that I kind of like in the urinary tract too is just, I'm a simple person, so I like simple analogies. So it's a system of pipes, right? You have urine or some sort of fluid that's trying to get out of the body. Urine is made in the kidneys. It travels down two thin tubes called the ureters and into the bladder. Now, if the prostate is so big, or that bladder has just been worn down from having to work so hard over many years, that system gets blocked, you begin to get urine that can actually back up into the kidneys. And unfortunately, we see patients weekly who go into kidney failure or renal failure as a result of this. And again, this is a really big deal. And usually when patients are heading in this direction, it's a much more serious problem, obviously. Patients can develop more what we call urinary incontinence or leakage of urine. And again, that irreversible damage to the bladder. Sometimes we get to the point we say, listen, your only option is managing your bladder with some sort of tube, some sort of catheter that comes out through the penis, or patients that have to self-catheterize, or even what's called a suprapubic tube, a little tube that goes below the belly button directly into the bladder. So obviously, if not every patient progresses in that direction, but some patients who have more severe BPH certainly can end up with some of these complications. An important take home is, talking to your urologist, talking to your primary care doctor about prostate cancer risk, I think is a quite important thing. BPH in general does not increase your cancer risk. So, we have a lot of people that when they come in for their initial consultation, their biggest worry is, I'm having these urinary symptoms. Does that mean I have cancer? No, BPH itself does not. However, there are still some tests and some things that we can do to make sure that this isn't a cancer issue and that this is more just a benign enlargement. So we'll go through a couple other slides. We're urologists, so we have kind of a twisted sense of humor. So kind of going into our next poll question here. So we'll go into this a little bit more, but this is a fun classic. Would you rather have a cystoscopy, which is a fun procedure that we do all the time, where we stick a little camera through the urethra and into the bladder, or would you rather play Scotty Scheffler in a televised event? So I actually don't know where I stand on this one. While it would be quite fun to play against Scotty Scheffler, I don't know if I'd hear the end of it from all my families and friends, and I'm not a very good golfer to begin with. So um, this is a tough one for me, and I see the crowds in lockstep with me. Kind of a 50-50 shot of whether or not you'd rather be embarrassed and humiliated on ABC on Masters Sunday versus a scope. So it's good to see that I'm right there with you guys. So jumping in a little bit more to BPH, how is this diagnosed? So a lot of this, frankly, is sort of talking with your urologist, going through your symptoms, and sort of gathering what are the symptoms that you're having, how much is this a bother to you, and kind of looking into things a little bit further. So a couple easy things that we typically do on your first visit. There's easy tests that we can do that are non or minimally invasive. Getting a urine test, making sure that there's nothing else going on with your urine that could be driving your symptoms. No infections, no blood in your urine. Some patients who are diabetic tend to spill a lot of sugar into the urine, which can cause a lot more symptoms that can replicate BPH or can be present at the same time as BPH. So with the urine test, again, it's a quick, easy test, non-invasive at all. There's another test that we do called a bladder scan, which we do, again, in every single one of our offices. This allows us to measure how much urine is left over in your bladder at the completion of urination. This is a really helpful tool for us, as well as when we're counseling patients, to really kind of identify those patients who might be at higher risk for some bladder deterioration, or maybe even experiencing some of that. And this kind of helps us confirm that even though you're having these symptoms, your bladder at this juncture is able to empty well. Another thing that really definitely all guys between 55 and 70 and some other patients sort of outside of that range, we really recommend getting what's called a PSA blood test, prostate specific antigen blood test. Now, this is a test that we use quite commonly to help rule out cancer. Most folks have their primary cares get this, but oftentimes we get people in our office who don't have a primary or maybe haven't seen them in a while. So this is another easy frontline test to just say, this is a benign prostate issue. This is not a cancerous issue. There's also everyone's favorite finger exam into the rectum. We call it a DRE, a digital rectal exam. So it sounds way more scientific, but pretty much we put our fingers in your rectum. We feel the prostate. And this does a couple things other than makes patients not want to come back and see us. Number one, it allows us to get a ballpark idea of the overall size of the gland. This can be helpful if there's a borderline PSA. This can be helpful if you do have majorly bothersome symptoms to kind of guide us a little bit more on where that next step might be. The other thing it's helpful for is if we feel a clear nodular area or something that feels very irregular. Sometimes this is an adjunct to the PSA test, which can help us sort of figure out, is this, again, a cancerous problem, or is this something that's more benign? Another thing that we are really pushing patients towards, and kind of going back to that notion of how do we keep an eye on your overall bladder health? If you haven't had rapid progression of symptoms and this is a gradual process, how do we know that you're not at that, potentially more dangerous spot? So in addition to checking the urine to make sure there's nothing going on, in addition to scanning your bladder to make sure you're emptying, there are some easier tests and some slightly more invasive tests that give us a lot more data. In my practice, I'm a lot more data driven. I like to give patients the autonomy to kind of make the best decisions for themselves and really gather as much data so we can give you the best advice to say, you know what, this is something that is very low grade. Let's keep an eye on it and get you back in 6 to 12 months. Or, your bladder's really showing some signs of wear and tear. I think we need to be a little bit more aggressive about this treatment. So there is a test that we do actually in all of our offices. It's called a Eurocuff. And so this fancy device over here, I promise it's not a torture device, and I promise it doesn't hurt. But essentially what this is, you can see the funnel on the right side of the screen. Essentially that funnel goes on the tip of the penis. You urinate into this machine, and it calculates a lot of different numbers to sort of give us an idea of how strong or how weak is your flow, how well or how poorly is your bladder contracting. Are you obstructed? Are you unobstructed? Are you at a point where your bladder is in really bad health, cannot generate a strong stream, and have a very weakened bladder contraction? So it's another tool that we use to help risk stratify folks. I find it incredibly useful. We're not giving you a general anesthetic. We're not putting scopes or tubes or anything inside of you. And again, I think a lot of patients like seeing this data to kind of steer them in one direction or another, especially if it's a more chronic issue that they've been dealing with. There's also what's called urodynamic testing. So it's similar to Eurocuff. It's a bit more invasive and probably gets a little bit more definitive information. But since UroCuff has been out, I've been steering a lot more patients to get UroCuff because, again, I think it's quicker, easier for patients, less invasive. There is a little catheter that goes into the urethra and sometimes into the rectum to get more detailed information. So more complex patients, patients with maybe a more challenging or different past medical history, neurologic history, those types of things tend to benefit a little bit more from that type of urodynamic testing. So I did have a quick question, and if you guys do have questions throughout the night, feel free to send those in. Some of them I'll go through while I'm talking, and others I may wait until the end. So this question was, what PSA scores correspond to low, medium, and high BPH? That's a great question. So in general, PSAs tend to rise the bigger glands get. Now, just because someone has a normal PSA doesn't necessarily mean that they don't have a prostate gland that's 5 times bigger than the normal one. But in general, they do tend to correlate as that PSA, slowly goes up at the same time that the overall volume of the prostate. It's a great transition actually into the next slide or two. So I know I partially answered it. I'll go into that a little bit more. So another more advanced option, if patients come into the office with more severe symptoms, maybe their post-void residual or that bladder scans up, or maybe their UroCuff showing that their flow is incredibly weak. There's a procedure we can do called a cystoscopy, which is, again, very similar to playing against Scotty Scheffler at Augusta on a Sunday. Very pleasant. But this is a procedure we can do under a local anesthetic. We can also do with a little bit of light sedation. Put some numbing lubricating jelly in through the tip of the penis, put a scope internal. And when I have patients that I'm talking to about this, my 2 main goals are, number one, making sure that there's nothing else bad going on. We want to make sure there's no scar tissue in the urethra that can kind of give you the same symptoms as an enlarged prostate. Let's make sure there's no tumors in the bladder. Let's make sure there's no stones in the bladder or anything else. So this is really, the slightly more invasive, but kind of a diagnostic test to really rule out the bad stuff, number one. Number two, this also allows us to get a little bit more of an exact measurement of your prostate. So typically when I have patients with BPH that are saying, you know what, the conservative stuff, which we'll go into in a second, is not quite helping me, or maybe I really don't want to take medications, or maybe my UroCuff or my post-void residual are a bit concerning. What do we do? Usually it's a scope, and usually it's what we call a transrectal ultrasound. So it's kind of a souped up version of everyone's favorite finger exam, the digital rectal exam. Again, with a little bit of sedation, we take a small ultrasound probe, we put it into the rectum, and it gives us an exact size and shape of the prostate. This data really helps us take the next step to say, what surgical procedure might you be a candidate for? And we'll go into those in a little bit. There's an incredibly wide range of procedures, which I think to patients can be quite overwhelming when you start doing research. You say, well, this one sounds good, this one doesn't sound so good. A lot of that is predicated on your specific prostate anatomy, not just saying, here's 10 procedures, this is Amazon, click on your button. Certain procedures are much better suited to certain patients, especially, based on your specific anatomy or your specific constellation of symptoms. Now, some patients, again, who have maybe a higher PSA score, going back to the question, oftentimes when we're doing a scope, if there is a little bit of an elevated PSA that we might be more concerned, sometimes at that time we'll do a prostate needle biopsy to rule out any sort of cancer. There are also very good imaging tests like MRIs that do a really good job at looking at the size of prostates, as well as looking for high-grade lesions that might be cancerous. So the PSA is a great tool, but I think it's only a piece of the data set that typically helps us rule out cancer if the number looks good, or if it is up a little bit higher, may trigger some more tests like an MRI or like a biopsy to get a little bit more information. So we'll take another poll here. We will go into some lifestyle changes. So we kind of talked about what is BPH, what are some things that we can do to get a little bit more information about. So we'll kind of jump into some lifestyle changes. Which of the following would be the hardest for you to give up or cut back on? Depending on the patient, I put a lot of fun things on here that all can be quite challenging. And before we take the next step, I like to tell patients as well that everyone's bladders and everyone's prostates are a little bit different. So a lot of this is individual to really have patients sort of figure out and determine which of these things might be more of a problem for them. And it sounds a little bit silly, but I like to tell patients to make a bladder diary. Write down everything that you're eating or drinking for a couple of days or a week. Write down those days where maybe we're going to the restroom every 60 minutes, or you had a couple episodes of leakage, or hey, I slept through the night most nights, and that night that I had, some spicy food for dinner, I was up 4 times. A lot of this is a little bit of, trial and error. Documenting these things for yourself to just kind of look back and say, okay, which days were bad, which days were good? What can I do to, cut out that may be a little bit more of a bladder irritant? So typically our algorithm is kind of start with the easy stuff with the lifestyle changes, look at other medical problems that you have, maybe cut back on certain medications or see which of those medications may be causing problems to be worse. There are then pills and different types of medications that we can give you. And then the end of the line, we start talking a little bit more about some procedures. So a couple things that you can do, making that bladder diary, seeing if it's, alcohol, caffeine, soda, spicy foods, acidic foods, again, really all the good stuff. And none of these things necessarily are going to be majorly problematic to cause cancer or cause other issues. A lot of this is just, these things get filtered out. The kidneys put some of these, the contents and the breakdown products into your urine. All that can be quite irritating to the bladder. Same thing with patients who are diabetics. Kidneys are smart and they filter out things that don't need to be in the blood. And sometimes that's glucose. If you're a diabetic, that glucose spills over. And all of a sudden that bladder is just a lot more irritated, a lot more frequency, a lot more nocturia or waking up at nighttime. Patients with predominantly nighttime symptoms, I say, again, this is probably common sense, but cut back on the fluid that you're drinking later in the day, or even cut back on anything you're having after dinner. Throughout the day, doing what's called timed voiding or double voiding. Getting on more of a regular schedule of, every 90 minutes or every 2 hours, even if I don't feel like I need to go, I'm going to go and I'm going to empty my bladder as much as possible. The double voiding is sometimes just relaxing some of those pelvic floor muscles to really make sure you're getting as empty as possible. So again, these are kind of the easy conservative things, built into this. There is a little bit more of a specific type of pelvic floor physical therapy that sometimes can be helpful for certain patients, if they're kind of doing all the conservative stuff. A lot of this, again, is just identifying those triggers. So there are a whole lot of medications that can certainly worsen symptoms. A lot of antihistamines. We have patients that come in, they were, having flu-like symptoms. They took some over-the-counter decongestion medications and ended up not being able to pee or having a really, really challenging time. Some of those medications can kind of tighten up the bladder neck or the prostate, make it a little bit more difficult. Patients who have had surgery, patients who are on pain meds, all of those types of things can impact your bladder and your prostate and make things a little bit more of a challenge. On the other end of the spectrum, we have a lot of patients that are on different types of water pills or different types of blood pressure pills or different things, for heart failure. A lot of those medications, unfortunately, are going to make you create more urine, which is going to cause these symptoms to flare up, especially if there's some underlying BPH issues. There are a lot of homeopathic medications out there. There's a lot that have been pretty well studied. Beware might be a little bit too strong, but I think a lot of these products that are out there, what I typically tell patients is these are not going to harm you, but typically there is a cost to them, and there's really no good randomized controlled trials to really prove that these are overly beneficial, particularly compared to some of the prescription strength medications. If you're taking these things out and they seem to help, keep it up. If you're really, looking for answers right now, I would warn you that that's probably not the best place to start looking, and I would advise you to get in to talk with your urologist. So kind of diving a little bit more into the medications. Typically, our first line medications involve a class of medications called alpha blockers. A lot of folks have heard of Flomax or Tamsulosin, and probably one of the more common ones. And the concept with all of these medications is they relax the muscle within the prostate and around the bladder neck, opens that area up to allow you to empty more effectively. The nice thing about alpha blockers in general, they tend to be cheap. They tend to be pretty easy, tend to have pretty minimal side effects. The ones that I caution patients about, if you have really low blood pressure or you get dizzy easily, some patients can have a little bit of dizziness or lightheadedness. So we typically recommend taking these before going to bed. That way, if you are a little dizzy, you're laying down in your bed, you're going to sleep soon anyway. This tends to be most common. There is what's called retrograde ejaculation, which sounds terrifying, but really all that it means is instead of ejaculating forward through the tip of the penis, these medications will relax that area that typically contracts to allow everything to be propelled forward. Unless you're actively trying to have kids, it's not the end of the world, but it does freak guys out if they don't know about it. So just a heads up with that. There is another class called 5-alpha reductase inhibitors. Finasteride, Proscar tends to be, again, the more common one there. That is a medication that slowly over time will shrink down the size of the prostate. It can artificially cut your PSA in half. The challenge with that medication, it's not immediate. So if your symptoms are really causing problems, it can take upwards of 6 months or even longer before you start to see more of an impact. The other thing, there can be some libido issues. There's some ED issues as a result. Again, some guys come in and say, I don't care about that stuff. I'm having trouble urinating and I really don't want a surgery. I'm okay trying to pills, trying different types of pills. So certainly an option. And again, that's on an individual basis. Some patients, really want to avoid those types of side effects, which is very, very reasonable. And again, that's when we start talking about, what else can we do other than these conservative behavioral modifications or kind of jumping into the easy medications. So this is what I picture most of my patients looking like as they're coming in to see me and reluctant to even talk about their symptoms because they're worried about where that exam might lead. So again, if the lifestyle changes aren't working, if the medications are either causing side effects or too much, of a nuisance, or your med list is already too long and you want to keep that down, typically we'll jump into some of the more advanced testing, cystoscopies, ultrasounds of the prostate, making, Eurocuff to really sort of get a baseline of where your bladder health is at this juncture and what's the exact anatomy. So this is a quick algorithm that I expect everyone to have memorized in the next 30 seconds. Typically, again, trial of medical therapy, there are a handful of different things that we can do. There are a couple other medications which can have some benefit based on the degree of symptoms and if they're more what we call obstructive symptoms versus irritative symptoms. And like you see on the right, there is a whole host of surgical options. So I did see a couple other questions come in. Are there things we can do to help shrink the prostate? Proscar or finasteride or those 5-alpha reductase inhibitors can shrink down the size of the prostate. There are different procedures that can do that, which we'll jump into. Another question about UroLift versus PAE. Great question and great segue. So we'll kind of talk about a handful of the more common types of BPH procedures. So the first is UroLift, and that's one that right now is doing a really good job with direct-to-consumer marketing. I'm sure on the radio or TV, you're seeing the fun videos of the fire hose of the ship in the harbor shooting water up in the air. So they do a great job, kind of speaking to patients that maybe haven't come in to see the urologist. So what this is a quick outpatient procedure, usually takes about 10 to 15 minutes. After we have that data of size and anatomy of your prostate, we take a small camera, we deploy typically around 4. The average is probably about 4 little implants that go into the prostate and essentially staple or pin back that prostate to open up that channel right through the middle of the prostate to allow you to urinate a lot better. The nice thing about this procedure, it is quick, it is straightforward. It is not something that requires an overnight stay. A vast majority of men have no catheter, and it's typically a lighter anesthesia, not something that all patients need a breathing tube for. So typically pretty quick and straightforward. This is a really nice procedure for certain patients. What I usually tell people, the advantage of this, it's quick, it's easy, it's straightforward. It's not an hour or 2 or 3 under anesthesia. It's pretty in and out procedure. The downsides of the procedure, it is a little bit newer. In terms of durability, if you're a 50-year-old guy and you have a larger prostate and say, I want to have one procedure and be done for the rest of my life, UroLift might buy you some time, but in terms of durability out to 20, 25 years, we don't really know yet. A little bit in jest, what I tell people before a UroLift is, you're not going to like me a whole lot for about a week or so. It's typically, burning, frequency, urgency, blood in the urine, just kind of some pelvic discomfort. And a lot of that is because we put those implants in there. Your prostate and your pelvic floor muscles just need a little bit of time to cool down. So I tell people to expect to have a rough first week, sometimes out to 2 weeks. We typically send you home with a handful of medications to help with inflammation and some of this irritation. But the nice thing about this, it does preserve ejaculation. So I did talk about that concept of retrograde ejaculation or backwards ejaculation. That is something that is stays on board while you're on Flomax, and with some of the more advanced procedures tends to be an irreversible thing. With UroLift, we don't typically see erectile or ejaculatory dysfunction. There are some questions in here. Does UroLift cut down on leakage? In some patients, it can. Now, again, the caveat is the first week or two, if your primary symptoms are more irritative, you're probably going to have a flare-up. And this is where I think the scope and really having your urologist hone in on individual symptoms to maybe steer you even away from UroLift. But in some patients, it certainly can help to kind of open that area up, make it easier for that bladder to empty more fully, especially if part of the issue is incomplete emptying. There's another question, is UroLift reversible? So it's not necessarily something that you go in and say, oh, it's in and it's bothering you, we're going to go in there and just make a little cut and remove it. Typically, in terms of being reversible or not, if you're still having symptoms, we usually bring you to the next type of procedure, which is a TURP. This is kind of the old school gold standard procedure. We know that it works. We've been doing it as long as urology is a field. So a TURP is a transurethral resection of the prostate, a fancy way of saying, similarly, we take a camera going through the tip of the penis under a general anesthetic. We go in there and essentially core out and shave out that prostate. This is a durable procedure. I typically tell patients that this is something that should last 8 to 10 years, if not a little bit longer. It is really good for unobstructing patients. So in patients who have maybe, had a UroLift 3, 4, 5 years ago and said, I initially did well, but things are kind of progressing and coming back, TURP's a nice option to go in there, and you can actually cut out the UroLift device at the same time as you're hollowing out that plastic or that prostatic urethral channel that's there. So again, this is typically an outpatient procedure. Depending on some other factors, occasionally your doctor will keep you overnight. I do a vast majority of mine same day. You do get a general anesthetic. Typically keep the catheter at least for a night or two. So the downside to this is there is a catheter that you have to have afterwards for a very brief period of time. The main reason for this is we're cutting the tissue rather than just pushing it. So it's a bit more invasive, but more durable. In patients that we do this for, I tell them to expect to have intermittent blood in the urine, typically out to about 2 weeks. The catheter can be a little bit irritating while it's in. There's a very low risk of erectile dysfunction or more challenging urination afterwards, but very low risk of developing some scar tissue. I had mentioned the retrograde ejaculation. That is something that's permanent with this. But again, for a lot of guys who are having these issues, that's not at the top of their checklist. The other nice thing about the procedure compared to a UroLift is we do remove all that tissue. That is all sent to the pathology lab to be looked at to make sure there's nothing cancerous. Another question in here, can you get a UroLift if your prostate is very large? You can. Now, most of the studies looking at UroLift, durability goes down. If those glands are a little bit bigger, you can deliver more implants in that area. Typically, when those glands are getting bigger than about 80 or more grams, and that's something again we measure on the transrectal ultrasound. Above that, your UroLift is probably not going to make a whole lot of sense. And sometimes even for smaller glands, you may just need less implants. And so that would be kind of at the discretion of your urologist. There are some other factors and things that we find on cystoscopy where patients can have what's called a median lobe or kind of a knuckle of prostate tissue that goes through. In my practice, I tend to find that those patients don't do as well with UroLift. You can still do a UroLift, but again, in my practice, they tend to be a lot less durable and patients are not as satisfied with a UroLift compared to a more definitive surgery like a TURP. There's another procedure called a green light, and this is a procedure that uses a laser, a green light laser to vaporize prostate tissue. So essentially just using a different type of energy rather than cutting the tissue, just vaporizing the tissue. Similar to a TURP, this is a general anesthesia. Similar to a TURP, it's outpatient, typically a catheter for a night or two. And this is good for kind of those medium-sized prostates. And oftentimes this will be the selected procedure if patients are on blood thinners and maybe can't get off of the anticoagulation or have to get on pretty quickly afterwards. So again, similar to a TURP, ejaculatory dysfunction or retrograde ejaculation is quite common. Very low risk of erectile dysfunction. Some irritative symptoms, frequency, urgency for a couple of weeks. Again, in my practice, I find that the irritative symptoms tend to be a little bit more predominant in a green light versus a TERP, which I think is probably just the way that the energy is dispersed throughout the prostate during the procedure. So we don't send any pathology because all this tissue is vaporized, but typically in terms of kind of stopping blood flow to the area, the green light does quite a good job. Another question that came in, my doctor prescribed tadalafil or generic Cialis to reduce symptoms, improve flow. It wasn't on my list. It's a little less common to see that, but there is some data out there that a daily low-dose Cialis, 5 milligrams of tadalafil, can be helpful. There are some other medications that slow down your bladder contractions, like Myrbetriq or Gemtesa, or another class of medications called anticholinergics. They're there. They tend to be kind of less of the heavy hitters in terms of BPH type symptoms. But in some patients who are having side effects with the other medications or maybe having some other ED issues, sometimes that can be a nice adjunct. It works a little bit differently than Flomax. In terms of the data, the Flomax tends to be a little bit more effective, but again, you can combine them or it can be something that you use as a monotherapy. Going into some other surgical treatments, there is a procedure called aquablation. We do have a couple doctors in our group that are doing this. So essentially, we're using water jets to kind of damage the prostate tissue to allow that tissue to shrink down. It's a robotic technology, not meaning that a robot does your surgery, but it kind of helps guide us in looking at the anatomy of the prostate throughout the procedure. And really, the thought is kind of ablating or killing off that prostate tissue in a larger proportion of the gland. So this can be done with larger glands. It does, again, require an anesthetic and oftentimes an overnight stay in the hospital. In terms of things that make it a little bit unique compared to, say a TERP or a green light, it does not have any impact on erectile or orgasmic function. And nearly all men are able to preserve that what we call antegrade ejaculation or normal ejaculation, and very rare to experience a postoperative incontinence. We do have a physician or two in our group who also do this procedure called a HOLEP, a holmium laser enucleation of the prostate. This tends to be a really nice procedure, but it's a little bit more of a specialized type. And essentially with this, we use a laser to core out what we call the benign adenoma of the prostate. So I kind of liken the prostate to an orange, where you have the rind of the orange which is the prostate capsule that we want to leave intact. We kind of go in there and find where the rind of the orange is, and the fruit of the orange, we kind of cut right on that area, remove and push all that into the bladder and chop up small pieces of it to remove it completely. This also requires general anesthetic, also requires a catheter. This is a nice procedure that can be done on some of the larger glands where things like UroLift or things like a TERP begin to get a little bit less effective as these prostates get above 80 and certainly above 100 grams. With this, ejaculatory dysfunction, like a TERP, can be common. Typically have you take it easy and still have a little bit of blood in the urine, intermittent blood in the urine for the first couple of weeks. And we are typically able to send this prostate tissue off to be looked at under a microscope to confirm no cancer. ITINS is another newer type of BPH procedure. This is, again, a little bit more specialized, a little bit less commonly used, but there's a device that is implanted right at the juncture of where the prostate and the bladder meet. This essentially creates pressure to decrease some blood flow in those areas and sort of reshape or remold the inner portion of the prostate where you urinate through. The device stays in for several days, and then you come back for this device to be removed. When I talked about patients not liking me a whole lot for a UroLift, this is another one that, while it is very minimally invasive because we're not cutting, there's no catheters in. This device, while it's in, can be a little bit irritating, but is nice for, again, a select group of patients where their anatomy may have a steeper bladder neck or smaller prostate glands that are obstructive. Kind of jumping into larger glands. So again, with the cystoscopy, with the truss, we're able to get exact anatomy. There are a couple different options when your gland gets bigger. One would be the HOLEP procedure. Another would be a robotic simple prostatectomy. The concept's the exact same as the HOLEP, but this is a much more commonly used procedure. Small incisions that are in the belly and essentially go in, scoop that prostate gland out. Minimally invasive procedure. You do typically have to have a catheter for about a week, stay overnight in the hospital. Patients who have HoLEPs, patients who have simple prostatectomies tend to be very, very satisfied patients after these procedures. They really debulk a lot of a lot of the obstructive prostate tissue that's there. You will have retrograde ejaculation after this. We tend to tell patients to take it a little bit easier after this procedure because we are making those abdominal incisions. In terms of real physical activity, heavy lifting, it's usually closer to about 3 to 4 weeks, just because it is a little bit more invasive, but also very, very definitive for much larger glands. So there is a newer option, which our group is actually rolling out. I believe in the next 3 or 4 weeks, we will have our first patient done. There's a surgery or a procedure that's been done by interventional radiologists for quite some time. The problem is we don't typically do this as urologists. So we have paired with some very highly skilled interventional radiologists who essentially will be doing nothing other than this procedure, prostate artery embolization. And how this procedure works, there will be a radiologist that performs a small stick in your groin, identifies where the blood vessels are to the prostate, and essentially is able to cut off the blood supply to a vast majority of the prostate, shrink it down in size without us having to cut on you, without us having to put a catheter on the inside. And so I think in terms of options, there's a lot out there. And this is just another kind of minimally invasive option. It really just involves light sedation. Most patients are not getting breathing tubes. There's not an overnight stay in the hospital. There's typically no catheter or anything or any scopes that are put on the inside. So the nice thing about this, there is less risk than obviously doing an abdominal operation. There's no overnight stay. And again, patients like this because, again, not everyone's super thrilled about the idea of having a catheter afterwards. So with PAE, this can be done for much larger glands and typically tends to be a little bit more effective for those larger glands. So I believe the first week of December, we're doing our first patients. I believe we already have patients booked out through, I heard, maybe February. So this is something definitely to pick the brain of your urologist once they have a better idea of what's going on and see, is this an option for me? Again, it preserves ejaculation. There's no cutting, no catheter. So certainly, I think a new weapon in our arsenal that we can offer within this group that a lot of urology groups across the country have not really utilized. I think in our group as well, we really haven't utilized it that well. Historically, there's only been a handful of radiologists around the greater Cincinnati area that even perform it. So it's been kind of spread out. So we just said, let's centralize this. Let's get the experts from the area and let's create a high volume center of excellence where we can really make an impact and give patients a really nice option other than some of the traditional surgical options. So I see a couple other questions here. Keep them coming. Happy to answer. Can anti-inflammatory medications cause urinary problems? Not typically. Now, narcotic or stronger pain meds can kind of slow down the bladder, but typically, Tylenol, Motrin, things like that won't cause urinary problems per se. They can impact your kidneys, so something you just need to be aware of. Another patient saying, since I was much younger, I go to the bathroom at least 25 times a day. There are tons of things that you can do. So could that be potentially from an enlarged prostate? Maybe, but if this is something you've been dealing with since you were a teenager, probably a little less likely. Some patients just have overactive bladders, and that sometimes it needs to be teased out a little bit from there's certainly some overlap between irritative overactive bladder symptoms and irritative prostate enlargement symptoms. So certainly something to talk to your urologist about. Things that are helpful in this situation, again, a scope. Let's make sure there's nothing else going on. Check an ultrasound of the prostate, see if there is enlargement. There are plenty of medications. I had mentioned Myrbetriq, Gemtesa, a class of medications called anticholinergics, which are kind of old school, but work well and they're cheaper, but they can have some more side effects. There are even procedures that you can do that kind of slow down some of those bladder contractions. Botox stimulator called an InterStim, which goes in your back. So those are a couple things that you could certainly do. But yeah, it sounds like if that's been an issue for a long period of time and you're going, every 30 minutes, day and night, definitely have that looked into. Meloxicam's another anti-inflammatory, typically not causing, a bladder to slow down or anything like that. Another question, what are the meds that we get after a urolift? So this, I think if you ask 10 different urologists, you're going to get 10 different answers. So for the most part, I will send patients home with a stronger anti-inflammatory medication. There's something called Toradol, which I think works quite well. Pyridium's another medication that can numb the urinary tract. Some people will give a short dose of steroids. I don't typically do that. If you're on active prostate medications, I usually just tell you to continue those through the urolift. That way, if you have this flare up and inflammation, you're keeping up with that. It's probably a little bit of voodoo urology that make us both feel better that we haven't changed anything. Sometimes we'll give a narcotic pain medication for a day or so if that discomfort's really bad. And there's other medications that we can give for overactive bladder, the ones that I had mentioned before, which can be quite helpful after a urolift. Symptoms that you would consider worthy of jumping into surgery. So number one would be if you're bothered enough by your symptoms where your quality of life is affected, you've done all the behavioral modifications, you either don't want to take medications, you failed medications, or you're having side effects with medications. Those are all patients that are candidates. Patients who have had issues with urinary retention or had to have catheters put in the past, absolutely worthy of a surgery, and we would probably push you to do something more aggressive to prevent that from happening. Sometimes when you have a surgery and you have what we call post-operative retention and can't pee afterwards, sometimes that's just kind of showing us the tip of the iceberg of, yes, you have some bladder and prostate issues that have probably gone, unaddressed, or you haven't really been aware of those as you should have. So retention issues, patients who develop bladder stones, patients with chronic urinary tract infections, or PVRs or post-void residuals that are rising, or kidney dysfunction as a result. Absolutely, all of those are really, by guidelines, should be having something procedural done a little bit more aggressively than patients who just say, well, I wake up once or twice and it's a little bit annoying. So in my practice, there's a couple of non-negotiables where I'm really going to push it towards surgery. A majority of my patients, it's how much is this impacting your day-to-day? Another patient here, can you have a PSA of 9 for several years and no cancer? Absolutely. I have patients that have had PSAs that are less than 4 and considered normal that have had horrible cancer. I've had guys that have PSAs that are 15 or 20 that I've biopsied and done every genomic test and every MRI that don't have it. There are some other tests that you can do, MRI, genetic testing, what we call a PHI score, or percent-free PSA, a whole host of different blood tests and imaging tests that can kind of give a little bit more information than just simply the PSA. Is PAE covered with Medicare? It should be. I don't want to speak for that. I am not an insurance expert, and there's a million different plans. But typically with PAE, coverage is getting better and better because I think the payers in Medicare are realizing that, yes, this is a minimally invasive option that's getting really good, durable results for patients, especially those patients who may not be super healthy or super willing to have a major abdominal operation for a prostate. But we do have a whole benefits department that is way smarter than me and can kind of look into all those things before any of that. What PSA number is something to be concerned about? This is a bad answer, but everybody's different. A lot of it is collecting data points from the past and kind of seeing where your number has been. A lot of it depends on your age. A lot of it depends on your family history. Typically the traditional way of thinking about it is if you're between the ages of 55 and 70, anything greater than 4 is abnormal. Some people would say if you're under 55 and your number's above, say 2.5 or so, that number would be considered abnormal. So each of these is kind of an individualized type of conversation. If you're older than 70 and your number's a little bit above 4, we get a little bit less worried about that. So we have a little bit of a higher threshold to jump into more diagnostic or invasive tests at that point. If there's no more questions, thank you guys so much for spending the night with us tonight. There is a link that should have hopefully popped up on the bottom of your screen. There's a taking the quiz. All this is kind of reviewing some of the things that we talked about tonight in terms of your personal urinary symptoms. We can calculate what's called an IPSS score, which is a really nice objective way of quantifying how much your symptoms are bothering you. A lot of patients come in and say, here's all my symptoms. I really don't know how to put it together. I'm kind of bothered. I don't know if I'm bothered enough to take meds or surgery. The IPSS is a really nice scoring system that allows us to objectively look at you and say, are your symptoms mild? Are they moderate? Are they severe? Excuse me. Might you benefit from some more advanced testing like a urocuff, like a scope, or might you benefit from even starting some medication? So I would encourage you to click the link. Should just be a few quick questions and kind of give you a better idea of where you stand on that. So again, thank you all so much. It's been great talking with you. Hopefully I answered all questions. And if I talk too fast for you, I'm sure there's going to be a recording on the website that you can go back through again, or reach out to your local urologist Yeah, thanks. Have a great night.